evening, everyone. On this National Science Day, Science and Technology Day evening, I welcome all of you with a great pleasure to join with us for this wonderful dermatology webinar. I welcome Dr. Nitin Patia, and I also welcome Dr. Amanjot Singh for this session. And I welcome the great speaker, Dr. Kavita, for our webinar session. See, you know that PYODERMA, particularly the canine PYODERMA, if we say, it is quite commonly seen in our practice. See, almost most of us are experiencing with the PYODERMA, and it's a hell of a problem. Actually, why it is like this? Because PYODERMA always comes as a secondary. We have to find out the cause for the PYODERMA. Then only we can have a complete cure. Of course, we have one or two PYODERMAs like German Shepherd PYODERMA and other things as a primary. So here the PYODERMA comes as a secondary thing for even any allergy or any parasite. It will be appearing as a secondary infection. So it is very, very important to identify the types of PYODERMA and where it is located. Accordingly, we can identify the cause and also to have a treatment. What is the step has to be done systematically. All those things, it is very, very important for a practitioner. That's why we thought we'll have this as a challenges in canine PYODERMA insight as an insight as a good topic. I think I'll hand over the thing to Dr. Nitin Bhatia to introduce our speaker. Thank you.
Thank you, sir. I don't need words to introduce Kavita. Dr. Kavita is a well-known veterinarian amongst all. Yes, she is currently working as professor and head cum director, Center of Advanced Faculty Training in Veterinary Clinical Medicine, and she is the department head of clinical medicine at Madras Veterinary College. She has 21 years of teaching and academic experience. She specializes on small animal internal medicine, endoscopy, and dermatology. She has to her credit around 100 articles. She has been chairman for many students who have done post graduation. To mention a few, there are 7 students and 2 PhD students. She has been remarkably involved in the creation of small animal dermatology ward at Madras Veterinary College, critical care medicine unit at Madras Veterinary College, and endoscopy unit. She has many awards to her credit. I'll not keep all of you waiting and not keep myself between you and the Dr. Kavita. Over to Dr. Kavita.
Hello, sir. Good evening to all. First of all, I thank Professor Dr. B. Nagarajan, founder of AVD, for his untired effort in conducting a series of webinars, especially on dermatology, for the past 1 year amid a difficult situation, that's COVID. I thank you, sir. Then I thank the knowledge partner, Dr. Nitin Patia, on behalf of INTAS Pharmaceutical, for both of them for giving opportunity to deliver a webinar today. And it's great privilege for me to present the lecture on the eve of National Science Day celebration. I welcome all the practicing vet and students for joining this webinar. Thank you, sir. Shall I start, sir?
Yeah.
Sure. Okay, sir.
Yeah.
Yeah, ma'am.
Okay. So, I welcome all of you for the webinar on challenges in canine PYODERMA and insight. So, in practice, especially small animal practice, 40% of the cases are pertaining to dermatological issues only. So, we need to update. That's important. And this PYODERMA, it's a very common terminology. It's not so difficult to diagnose or treat as if it may look very simple. But the problem arises, for example, if the case comes and you are diagnosed with some bacterial infection, and you will be prescribing antibiotic and some topical preparation also. And so after a few weeks, 1 or 2 weeks, again the case will come presented with same issue, and it become frustrating to both clients as well as attending vet, because PYODERMA, though it appears very superficial, as Dr. Professor Nagaraj said, primary is very rare. It is a secondary to underlying issue. So PYODERMA occur as a skin issue, but the underlying issues are either allergic predisposition like atrophy or food allergy or flea allergic dermatitis, or else it may be due to some endocrinopathy like hypothyroidism, hypercortisonism, or it could be underlying parasitic etiology. So unless we diagnose the underlying etiology, but mere antibiotic will not give complete remission of the disease. That's why it poses challenge to the practitioner. Number two, the inadvertent use of antibiotic. I can say the antibiotic should be used judiciously, like the dosage, interval, and duration. So, and the antibiotic resistant strains are nowadays coming up due to these like resistant strains are very common. Even with multi-drug resistance are nowadays we have encountered in practice based on our research. And third challenge is from the client side, compliance. Because unlike other days of internal medicine, if you administer antibiotic for few days, the problem will not get resolved. So we need to give weeks together, and it requires most of the time topical application like giving a shampoo, bathing like that. So it is a cumbersome, time consuming and cost effective, and that's why the three main challenges are faced by the practitioners in canine PYODERMA. So with this, I am just going to the topic. So to get complete clinical remission, we must understand about the disease proper. So canine PYODERMA is the most common skin disease of the dog among the other skin dermatoses. Because if you take demodicosis or atrophy or food allergy, they are separate disease entity. But PYODERMA occurs along with all other dermatoses. That is why it is a very common skin disease. And there are various classification we are going to see, and diagnosis, and how to select the antimicrobial drug, and certain things about multi-drug resistance we are going to see in this lecture. So, as the term indicates, the PYODERMA can be very superficial or deep, or it can be classified as a primary or secondary. Before going to that, unlike other species, canines are highly prone for skin diseases, especially bacterial skin disease. There may be species difference like anatomy of the skin. The epidermal layer is thin when compared to other species. So the barrier functions are often get affected. Apart from the pH of the skin, when in dog pH it is almost neutral to alkaline when compared to other species, especially human, it is acidic. So that's why even our dog skin is highly sensitive than our baby skin. So we need to take due care in selecting our normal shampoos or whatever thing in a normal practice. So there are normal commensal on the skin. So the canine skin is not devoid of any infection. Normal pathogens will be there, that is microbes like commensal, bacteria, yeast, fungi, because even the puppies may harbor bacteria on the skin even as early as 7 days of age. So the organisms are ubiquitous in nature. They can be from oral saliva or excretory side, and they are contaminant on the skin. So until and unless the dog's skin microenvironment is not get changed, it's due to presence of parasite or nutrition, altered nutrition, then this bacteria will get upper hand. So whenever the skin surface is broken due to presence of some external parasites or due to that is a skin pruritus due to underlying it cause, and there is a chronic exposure to moisture, and there is a poor circulation on the skin, and whenever the general immune competency is impaired, during this situation, the bacteria may get upper hand and get multiply and it cause disease. So normally there are various strains of bacteria isolated from the dog skin. Mainly gram-positive cocci are common. They are Staphylococcus pseudo-intermedius. Previously it was called as Staphylococcus intermedius. And there are coagulous negative Staphylococcus are there, like Staphylococcus epidermis and other strains. And luckily Staphylococcus aureus we have not come across. If Staphylococcus aureus present, they are from pet owners. They are mainly dogs get the Staphylococcus aureus strain from their clients only. And this is a common bacteria causing superficial pyoderma. And deep pyoderma, mainly gram-negative organism like E. coli, Proteus, and Pseudomonas species. So, for the bacterial skin disease to occur, there are various risk factors. They are all always present on the in dog diseases like allergies, as I said earlier, food allergy, atopy, and flea allergy. So they always they are risk factors for the pyoderma, and fungal infection, that is dermatophytosis, and endocrine diseases like hypothyroidism, hyperretinocortism, then sex hormone related dermatosis. Then certain immune competence diseases, general immune systems get altered, it will always end up in skin disease. And sometimes whenever there is seborrhea, that is disorders of sebaceous gland, they also contribute to pyoderma. And sometimes the breed, body conformation itself may predispose the animal to go for skin disease, like excessive skin folds are present in obese dog, or it may be a breed itself like a bulldog or a bull mastiff or a pug like that, or sometimes due to trauma. So mites, ticks, fleas, yeast, fungi, these are all the main risk factors for occurrence of pyoderma. So how the disease occurs? This normal 90% of the skin bacterial skin disease is caused by Staphylococcus pseudo-intermedius only. So normally the organism present on the skin, and whenever the ecosystem equilibrium is disturbed by changes in the skin microenvironment, then these organisms get colonized on the surface of the skin initially, and it mainly triggers the immune system in form of inflammatory cells infiltration like neutrophil and macrophages, and it or sometimes it may induce cell-mediated immunity and antibody. So resolution is mainly by inflammatory response, which is responsible for the clinical signs of pyoderma. So there are normally this picture shows how the bacteria colonizes the primarily the epidermal layer of the skin, and then it slowly invades into through the hair follicles, causes folliculitis, and then a ruptured follicle spread the microorganism into the dermis and causes furunculosis and cellulitis. So like this, the organism causes different stages of infection. So as the term, most of the time you may think pyoderma means always presence of pustules on the skin. It is not so. So it is presented as various form. So normally superficial pyoderma, it affects the entire dorsum of the body or trunk. Whereas deep pyoderma, mainly it localized to particular region like chin, nose, pressure points, feet, or it could be generalized under skin folds. So the pyodermas are described, the skin lesions are described as papule, that is solid elevation, or pustules, sometimes crust, presence of a scab and crust, and this is the epidermal colorate and hyperpigmented spot, alopecia, lichenification, and presence of abscess formation, small abscess or cellulitis. So it can be presented as any form. So going to the type of pyoderma, first thing is surface pyoderma. As the term indicates, the organism invade only the epidermal layer, very superficial layer of the skin, and the main under this surface pyoderma, pyotraumatic dermatitis, or it's called as a hot spot. That is acute moist dermatitis, popularly known as hot spot. It is, as the term indicates, the onset of lesion is so acute. All of a sudden, usually occurs in hairy breed dog, it's very common. Within 1 or 2 days, the animal develop moist, exudative, erythematous lesion, highly painful and pruritic, and the rapid progression. So small lesion will spread into big lesion, and there will be very much self-infliction is common. So it's common in thickly hair-coated dog, and the common locations are either on the back or lumbar region of the animal or on the cheek of the animal. So it is whenever these lesions are present, the underlying pathology could be, number one, if the lesion is on the lumbar region, it is flea allergic dermatitis. So animal is having highly pruritic lesions due to presence of flea allergens. And number two, if the lesions occur like this, it could be persistent otitis, mainly due to atopic skin disease. So acute hot spots are mainly indicative of pruritic skin disease. Number one, flea allergic dermatitis, and then atopic skin disease with otitis. And sometimes you may get even in food allergy also. So this is very superficial, and sometimes you may not see the lesion, the extent of lesion. There you can see only a matted hairs with moist, exudative and odorous lesion. You need to clip the hair so that you can see the clear lesion. It's purely on the surface of the skin. It's called as hot spot or pyotraumatic, because the animal constantly scratches on the area, and it is called as acute moist dermatitis. And next one is another category under surface pyoderma is intertrigo, that is skin fold pyoderma. This is mainly occurs due to anatomical predisposition, as I said earlier. So there are wherever the skin folds are present, like lip folds in spaniels, or facial folds in bulldog or pug, and vulval folds in obese bitches. So this skin fold, it creates a warm, moist, dark environment, which is ideal for the bacterial proliferation. So this is the main predisposing factor. And these infections are characterized by exudative, odoriferous, erythematous lesion within the skin fold. So this is the one classical example for intertrigo. And another very common occurrence is in bitches immediately after whelping, in between the mammary gland, that is teeth. You can appreciate if the engorged teeth, between engorged teeth, you can see erythematous and oozing highly painful. Most of the surface pyoderma are painful. So this is also common in recently whelped bitches. And very rarely you can get in vaginal folds also in obese dog, vaginal fold or tail folds, you may get skin fold pyoderma. And another category under surface pyoderma is mucocutaneous pyoderma. It is mainly on the oral cavity between the lips. So the etiology is unknown, but it may be considered as under skin fold pyoderma. And so along with the lip margin, you may get erythema and moist oozy lesion. So next is superficial pyoderma. This is the most common canine bacterial skin disease, and it is among the most common canine dermatosis. So among overall dermatosis also superficial pyoderma is common. Among the bacterial skin disease, superficial pyoderma is the commonest occurrence. And most of the research nowadays is going on this area only, how to manage superficial pyoderma. Once again, superficial pyoderma also occurs in various forms. So, like impetigo, superficial spreading pyoderma, then superficial folliculitis. So, impetigo, so most of the practitioners you could come across, it's a very common in young puppies under ventral abdomen. You can see the intact pustules. Usually, intact pustules are rarely seen in adult dogs because the dog epidermal layer is very thin. Most of the time, the papule formation initially followed with pustule and it will rupture. So you cannot see the intact pustule except in impetigo in juvenile cases, especially on the wherever the hairs are very sparse on the ventral abdomen, you can see the intact pustules. So with the erythema and pustule, you can able to see, and this is only just under the stratum corneum. It has not gone deep into the follicles. It is only affecting the colonization of bacteria on the epidermis, very, very superficial, common in puppies. Then this is the common one, superficial spreading pyoderma. So now you can see here scab-like thing on the edges of the lesion. So this is epidermal colorate. You can see this epidermal colorate. It is distinct to superficial pyoderma. There is a characterized by centrifugally progressive erythema and expanding peripheral epidermal colorate. So this can be seen alone or together with superficial folliculitis. So most of the time it may be seen as a lesion of only epidermis, or it could be associated with deep folliculitis. This is the common form of pyoderma once again. And superficial folliculitis. So this is the most common bacterial skin disease in dogs. Most of the time, in practice, you may misdiagnose this case as dermatophytosis because the lesions are only multifocal alopecia. So whenever you will not see any erythema or epidermal colorate or pustule, papule, always you think about whenever the alopecias are multifocal and circumscribed, you may think about fungal disease. But this is the commonest form of folliculitis, and especially it occurs appreciated in short-haired breed dog, otherwise known as short-haired pyoderma, like Doberman and even Dachshund. In these breeds, you can even Labrador, you can see the multifocal alopecia, and sometimes inside you can see the hyperpigmentation. So the infection is within the hair follicle. So even though it appears only loss of hair, the organism invaded into the hair follicle. Initially, it could have started as papule and a short pustular phase and then develops as a crust. Alopecia is the common feature and is characterized with distinct circular patches of hair loss surrounding previously affected hair follicle. So chronically leads to generalized moth-eaten appearance. This is the terminology used for superficial folliculitis or shorter breed pyoderma, moth-eaten appearance. It is common in short-coated breed. So, if you carefully examine the periphery of lesion or alopecia, it may reveal individual peripheral colorate or coalescing colorate. So this is also a common thing. If the case is only treated with antifungal shampoo or oral antifungal agent, then the condition will persist. So this is the common form of superficial pyoderma. So next is deep pyoderma. Deep pyoderma means, as I said earlier, the organism it went deep into the follicle and the follicle gets ruptured and spread into dermis. Always there will be formation of scar tissue with a sequestrated pyogranuloma. And it is less common when compared to superficial pyoderma. Once again, it could be classified into various forms: deep folliculitis, furunculosis, cellulitis. So most of the time, the lesion ulcerate and leading to draining fistulas. Pain or pruritus are commonly present, and it could be a regional or there will be generalized lymphadenopathy also can be observed. So mostly the common conditions comes under deep pyoderma are muscle folliculitis, furunculosis, that is canine acne, then pyotraumatic folliculitis and pedal folliculitis, and a callus pyoderma. So you could have seen in a larger breed dog on pressure points like elbow joint or hop joint, there will be hyperpigmentation, lichenification, thickening, scaling. That is one kind of deep pyoderma. And German Shepherd pyoderma and nasal folliculitis furunculosis, they are also coming under deep pyoderma. So you can see some pictures of deep pyoderma. Always, whenever you appreciate blood with papules and it is a characteristic for deep pyoderma. So you can appreciate could be a generalized form affecting throughout the body, or it could be only on a pododermatitis. So the common differential diagnosis for deep pyoderma is demodicosis. So you should not miss demodex in these lesions. Always you should go for deep skin therapy. And acrylic granuloma, so this is also a one form of deep pyoderma. You can see ulcerative lesion and erythema, and sometimes you may see the granulation tissue also. So this is not a primary bacterial disease, and you may be knowing about acrylic granuloma. It is a constant leaking of either metacarpal or metatarsal area. Either it could be attention-seeking behavior, psychogenic, or most of the time, 90% of acrylic granuloma are associated with atopic skin disease or food allergy or any other autoimmune skin disease, but highly pruritic skin disease. So we need to address the underlying etiology along with managing the bacterial skin disease. This is the one form of highly challenging granuloma. And this is another presentation of bacterial skin disease. I can say it's juvenile cellulitis. So usually puppies at the age of 45 days to 3 months, there will be occurrence of cellulitis around the muzzle and ocular and even compromising the ear pinna, and there will be numerous abscess formation on the body. There will be enlargement of lymph node, and it will convert into abscess and it will burst out and oozing lesion. And this may occur in association with the vaccination or without vaccination. Like after administering vaccine, after a few days of that, animal may develop a lesion like this, along with that rise in temperature and highly lethargic lameness like that. So this is actually, even though the disease appears like bacterial skin disease, the underlying etiology could be usually unknown, but could be narrowed down to immune system stimulation. So that is why in these cases, high dose steroid administration is highly warranted apart from your antibiotic therapy. So this also, this lesion, as the animal age advances also, you can see the scar on the face in most of the dogs. This is otherwise known as puppy strangles. So deep pyodermas is always difficult to treat than the superficial pyoderma, and mostly it is chronic, and the pathogens are always resistant to most of the antibiotic, and it involves frequently Staphylococcus pseudointermediates and gram-negative rods like Pseudomonas, E. coli, and Proteus. So, regarding coming to the diagnosis of bacterial skin disease, you may say it is very obvious. It is you can see with the naked eye the lesions are very typical. When we need to bother much by seeing the dog, we can give a treatment, but it is not so. So minimum protocol is needed to exclude some disease or the underlying etiology you can address. So number one is cytologic examination with the impression smear and skin scrapings, bacterial culture and sensitivity, and very rarely you may require a skin biopsy. So all these things are performed to determine the predisposing cause. Okay. So what is on the skin cytology? Just a direct impression smear over the lesion. You can just stain it and see under a microscope. You need to demonstrate some organism. Cocci, like cocci are very common. And this cytology is actually it's a reliable, rapid and cost-effective procedure. You can go for direct impression smear, or even you can collect from intact pustule also. So you are going for cytology, suppose the typical lesions are not present, there's no pustule, but you can go for the impression smear over the area, and sometimes the animal may not respond to your routine antibiotic therapy. So first you go for cytology. cytology. If you are appreciating organism on the slide, then we need to go for bacterial culture, and based on the ABST, we need to select the antibiotic. In that way, cytology is highly useful. So normally bacterial infection, always it attract the inflammatory cells like neutrophils. There will be different stage, mature, immature, degenerative neutrophils. You can see the organism inside the cell, and even chronic disease, you may get organism on the lymphocyte and macrophages. That is that indicate the animal is active immune system is functioning. Very rarely you can appreciate eosinophils also, that indicate allergen based disease. So most of the time you will appreciate cocci, gram-positive cocci. It's suggestive of Staphylococcus pseudointermediates. You need not go for any other culture or a specific biochemical test to prove the organism. Mere presence of cocci, because at field level we won't get all the facility, but cytology can be done. So intracellular indicate the immune response by the host is good and the active disease status is there. Sometimes the organisms are present extracellular. But one interesting thing, absence of intracellular bacteria or inflammatory cell do not rule out bacterial infection. Suppose you have taken, you are suspecting bacterial disease and the animal is not responding to antibiotic treatment. You have taken cytology. On the smear, you are unable to appreciate bacteria. It will not say there is absence of bacterial disease, because the animal may be under immunosuppressive disease, or it may be under treatment with steroid, long-term steroid, so you will not appreciate the organism. Then, so we need to differentiate the pyoderma from other diseases or underlying pathology. Number one is dermatophytosis. So in our dermatology unit, renowned dermatologist Dr. Nadu, he is looking for fluorescence under white, that is wood slump. So either a dermatophytosis, if you suspect, you can go for wood slam examination, or else you can go for hair plucking to appreciate a spores on hair shaft under microscope. Then another is demodicosis, another important disease. By skin scraping, you need to rule out. Then sometimes the pustules may be sterile, they may not be bacteria. So it may be associated with some autoimmune skin disease like pemphigus, because lesions look alike on a mucocutaneous junction on the face or digits. You may get erythema, pustules like that. So in that case, absence of bacteria and presence of acantholytic cells, histopathology, and negative culture result will rule out primary bacterial disease. It could be a disease of other etiology. So skin scraping, in practice, you should, in all the cases, in all the dermatological cases, you need to do scraping first to rule out parasitic skin disease before going for, because there are various drugs come up in the market. There are much advances in the treatment, but unless you diagnose the proper disease, your advanced treatment will not be of useful to the animal. So skin scraping, though it looks very simple, it gives lot of information. So you go for pressing the lesion, you go for deep scraping until the blood oozes. You can appreciate always demodex. So like this, if the lesions are alopecia, crusty, and papular on the face or trunk, so immediately you should not give antibiotic, and so in the case, you take scraping and you just roll out demodex. Then coming to bacterial culture and sensitivity. So when all the case will not go for bacterial culture and sensitivity, it's not feasible under field condition. So whenever your treatment failure occurs, like you are given the proper selected proper antibiotic and they are given a course of treatment also correct, in spite of that the lesions are present, like there is no improvement in lesion, there are emergence of new lesions, then you consider the animal is, that is it's a case is refractory to the treatment and there are multiple relapses occur, or it may be if there is deep pyoderma, necessarily you need to go for bacterial culture, especially the demodicosis and other pododermatitis. Always we will go for bacterial culture and sensitivity. So, and most of the time culture may not be performed on open lesion. For example, if there is papules or pustules are there, then intact papule and pustule you need to select for taking sample. So either you can collect from pustule, furuncles or nodules, that will give more information. So this is the gram-positive cocci, numerous grapes-like thing. It's a common bacteria, Staphylococcus. So mostly the swab that is used for a bacterial culture, instead of like this normal birds, it is better to go for a thin culture tube. That is a swab, so that even small papule or nodule, you can collect material without any contamination from other side. So there are guidelines how to collect the swab from the lesion. There is pustule is there, intact pustule. Always any bacterial culture, you should not apply any disinfectant on the that's antiseptic on the surface of the skin lesion, and it's better to clip the hair around the lesion. And if the pustule is intact, then you can just make a small nick with a narrow gauge needle. And if there is some material on the needle, you can just spread it over the swab, or else after making a nick, just apply the swab on the lesion, and you will get the, sometime, most of the time, the discharge will be hemopurulent, or you could say sanguinopurulent. That is also ideal for culture. Then crust. Crust, suppose there is epidermal colorata there and crusty lesions are there. Then you use, once again, don't apply any disinfectant and use sterile needle to lift the edge of the crust and test the sterile swab to exposed skin surface. So under the crust, you just expose the crust and take the culture. Then epidermal colorate is there. Once again, don't apply any disinfection and clip the hair around with the scissors and roll the sterile swab across the border of colorate 2 or 3 times. Then if it is papule, you can sample by needle aspiration or biopsy. So this is the way how you need to collect the sample for bacterial culture in a sterile manner. So skin biopsy, this is the last option. If you are unable to get any information, what is the underlying pathology, then like sebaceous glanditis or any other underlying pathology is there. Skin biopsy is the, and it will give definite diagnosis for the underlying etiology. And apart from this skin test, you need to evaluate the immune competence of the animal, because very rarely it is useful at field level. That is, you need to go for serum immunoglobulin quantification, blood count, and neutrophil function test like that. But normal clinical pathology impression, there is absolute neutrophilia with the lymphocyte count of at least 1000 to 1500 cells. Then the animal is immunologically normal. Then apart from this, we need to go for endocrine profile. If you suspect hypothyroidism, like thyroid profile, and if you suspect Cushing disease, then you can go for dexamethasone suppression test. So in a normal pyoderma, you will start with routine treatment. If the case is challenging, you need to go for a battery of tests. Now coming to the management. So it includes both systemic antibiotic therapy in combination with topical therapy. So only topical therapy or only systemic therapy may not be of useful. So combination always works. It will reduce the frequency or duration of treatment of systemic antibiotic if topical therapy is added. In some of the pyoderma, with the mere topical therapy alone, you can manage without going for systemic antibiotic therapy. And nowadays, the advancement is you need to go for immunomodulatory therapy to avoid the recurrence of infection if available. So coming to topical therapy, so the more common one is there are topical therapy. It could be a shampoo therapy or a application of ointment, gel, cream, lotion. Once again, how to select this? Whenever the problem is generalized one, shampoo is the ideal choice. If the infection is focal, it's only a regional small area, then you can go for a lotion, cream, ointment. So generalized infection, we need to select the shampoo bath or whirlpool therapy like that. So what is the advantage of shampoo? It reduces the cutaneous bacterial population and it removes the debris and allow the direct contact between the active ingredient and the organism, and it promotes drainage, everything. So, and another advantage, some case of superficial pyoderma can be treated with shampoo alone. You need not go for even systemic antibacterial therapy. And even long-term use in a recurrent superficial folliculitis, you can manage only with, for example, the recurrent superficial folliculitis is due to underlying cause of endocrine dermatosis or allergic skin disease. Without antibiotic, there is systemic antibiotic, you can manage because you know the underlying issue, you are addressing that one. So along with that, you can go for only topical therapy like shampoo one. So they have prophylactic effect if used regularly in this patient, in allergic patient as well as endocrine dermatosis. Topical shampoo can be used regularly. And deep pyoderma, mostly it needs to be clipped before using shampoo. So any pyoderma, if it is generalized, it's better to clip the hair and then so that there will be better contact with the active ingredient. And once again, how often we need to give shampoo bath, medicated shampoo bath, it depends on the distribution of lesion and intensity of the disease. Starting from even some cases, suppose furunculosis or cellulitis, very severe disease, even alternate days you can give shampoo bath. Otherwise, you can give twice or thrice in a week. So the widely used, commonly available antibacterial shampoos contain, chlorhexidine and either benzyl peroxide or benzyl peroxide with sulfur. So chlorhexidine, it is an antiseptic, it is active against bacteria, and it have bactericidal action, and it is non-toxic and non-irritant. So 2 to 3% formulations are available. So most of the time, chlorhexidine shampoos are available as alone or in combination with other antifungal also. Then benzyl peroxide. So this is the superior, I can say, superior antibacterial shampoo or antiseptic shampoo. So how it functions, it lowers the skin pH. So most of the microbes multiply with the alkaline pH. So if you reduce the skin pH by using this component, it prevents the bacterial multiplication. And once again, it is an oxidizing agent, and it's an excellent follicular flushing and keratolytic activity, degreasing and comedolytic activity or additional benefit. That is why whenever you are suspecting follicular, that is bacterial folliculitis and the PYODERMA, benzoyl peroxide containing shampoos are superior. So that's available as 2 to 3% solution. So now coming to antibacterial creams and ointments, there are many preparations are available like skin or zincoderm or mupirocin ointment. There are various add-on come up in the market. Mainly these cream and ointments are indicated for small area of infection, not for generalized. So mainly they are useful in intertrigo. So we have seen already, that is a skin fold PYODERMA. So only a particular region, either on the neck, that is a neck fold, or it may be on the between the mammary gland. So you will get focal PYODERMA, then mucocutaneous PYODERMA, muscle folliculitis, furunculosis or canine acne. Once again, callus PYODERMA on the pressure points. Then pyotraumatic folliculitis and pedal folliculitis or furunculosis. So in these cases, you can choose antibacterial cream or ointment, and most of the time they are highly painful and pruritic. So short course of steroid also you can include for these diseases. So mupirocin, it is a potent topical antibiotic, and it is it should not be used against the mucosal surface, and if you apply for larger area, it have potential of nephrotoxicity. So, and 2% mupirocin is available, and another antibacterial action is that is silver sulfadiazine cream. This also works against the acute moist dermatitis. So once again, these ointments, creams, or judiciously should be used. Suppose most of the commercial preparation, they do come with some steroid, either betamethasone or triamcinolone or some kind of steroids are there. So long-term usage of this may go for iatrogenic Cushing disease on the particular area. So coming to systemic antimicrobial drug usage. So this is the important part of our this lecture, I can say. So there are a healthy number of antibiotics are available in the market. Either it could be that is beta-lactam antibiotic or fluoroquinolone or amloglycoside or macrolides or sulfonamides, and each have its own action. Either they could be bactericidal, bacteriostatic, narrow spectrum, broad spectrum. How to select the antibiotic? It once again depends on the patient or individual case. So whether it's a puppy or it is an adult dog, whether it is having any drug allergy or not, or it has some other internal issues like any systemic illness is there. So there are various factors influence the selection of antibiotic. Once again, cost also plays a major role, and frequency of administration. Because most of the time skin disease, the administration for weeks together. So once a day is more comfortable ideally. So you need to select the antibiotic accordingly. And you expect long duration of treatment. So we need to continue the treatment for long term. Accordingly, antibiotic with less side effect usually will select. So most of the time, how you are giving antibiotic is based on only empirical based on or based on your that is experience. But very rarely you will go for cultural sensitivity. But as I said earlier, bacterial infection, PYODERMA, 90% it is caused by Staphylococcus pseudo-intermedius. So these gram-positive cocci, and they produce a beta-lactamase enzyme. So always keep in mind, 50% of this organism causes beta-lactamase. So you need to select a beta-lactamase inhibitor. And it's better to select narrow spectrum activity initial treatment. Don't go for broad spectrum immediately. And it should have minimum side effect as well as it should be cost effective. So you can say the antibiotic classified different way. That is a time dependent antibiotic. That is, you need to give a specified dosing interval for maximum efficacy. Suppose the antibiotic is indicated twice or thrice, you need to follow that one. Then only the antibiotic will reach remains above the minimum inhibitory concentration. They are mainly cephalosporin, beta-lactam-resistant penicillin, macrolides, and lincosamides. So they are mainly dependent on time dependent, that is frequency of administration. And another group of drugs, they are concentration dependent antibiotic like a fluoroquinolone and amyloglycoside. So according to the dosage, the effect will differ. For example, if you administer fluoroquinolone 5 mg per kg or 10 mg per kg, accordingly the bacterial killing capacity of the drug vary. So this is the concentration dependent, and most of the time they are best given at a higher dose once daily. So you need not go for these drugs based on the minimum inhibitory concentration. We need to maintain the therapeutic level by increasing the frequency. But here you need to achieve the target dose by giving higher dosage once daily. This is for concentration dependent antibiotic. So there are various classification of antibiotics like macrolides and lincosamide. Erythromycins are bacteriostatic, but very rarely we are using this. Lincomycin and clindamycin can also be used, but it is a little bit costlier. Then potentiated sulfonamides, because for any PYODERMA, it's a first line antibiotic choice. You can go for potentiated sulfonamide. That is but in this drug also resistance is increasing, but the major disadvantage is keratoconjunctivitis sicca and non-specific polyarthritis. So we are not frequently going for a potentiated sulfonamide, and penicillins that are resistant to beta-lactamase. So mere amoxicillin, ampicillin, they are not effective against PYODERMA, but they can be added with clavulanic acid, amoxicillin clavulanic acid. They are superior in treating PYODERMA. Cephalosporin, it's a broad spectrum. The different generation, first generation, second generation, third generation. So these are actually, they will give excellent clinical efficacy. But some drugs are twice daily you need to administer, and some drugs like a third generation you can give once a day. Sometimes some strains may develop resistance against this cephalosporin, and this also cost-wise also it is economical. So fluoroquinolones, endofloxacin or norfloxacin, they are excellent antibacterial. They are broad spectrum bactericidal antibiotic. The advantage is once daily, and it has outstanding tissue penetration, and it active against all kind of bacteria, so gram-positive or negative. And only thing, you cannot use it in growing dogs or puppies, and it may cause articular damage. So these fluoroquinolones, always you reserve it for challenge cases like severe chronic deep pyoderma where no other antibiotic are effective. It's better not to select fluoroquinolone in a fresh case. You go for potentiated that is sulfonamide or amoxicillin clavulanic or cephalosporin. You reserve this drug for next step. So, how to administer, then first selection of drug, then how long we need to administer. So dosage is already indicated. You need to administer according to the indicated dose. So how long we need to give antibiotic, that is until complete elimination of bacterial infection rather than simple transient remission is achieved. So there should not be any clinical signs on the animal. So, for example, it is recommended to continue therapy for at least 1 week beyond the clinical cure for superficial pyoderma. Just imagine superficial pyoderma, the normal treatment oral antibiotic indicated is minimum 3 weeks. So, if there is complete remission is there after 3 weeks of treatment, there is no skin lesion. Even then, you need to continue the oral antibiotic for another 1 week. That is this. So minimum 4 weeks you need to administer antibiotic for superficial pyoderma. And for deep pyoderma, minimum you need to give 6 to 8 weeks. That is the oral antibiotic treatment indicated is 6 to 8 weeks. So minimum of 2 weeks beyond the clinical cure. I mean, you need to give 8 to 12 weeks of duration of antibiotic so that you will get a complete remission, or there will be a recurrence of infection, or there will be, if you administer antibiotic for a short period, there will be development of resistant strain. That is the challenge. So, there is antimicrobial guidelines for superficial bacterial folliculitis. That is formulated by Working Group of International Society for Companion Animal Infectious Disease, specifically for superficial. So they have worked with a team of people across the world. They found and they did research on superficial bacterial folliculitis, and they come with some standard guideline accordingly what they say. So first tier antibiotics, when they are used, that is primary choice empirical therapy. Empirical therapy, that is one thing is important. Suppose in region specific, some organism may differ. Even though Staphylococcus pseudoinflammatory is so common, there may be occurrence of other cocci also in your area. So initial study, you just did your practice in your area, you identify certain bacteria and the susceptibility for the thing. So based on your experience on this, you will be selecting first tier antibiotic. It could be clindamycin or lincomycin, or first generation cephalosporin, amoxicillin clavulanic, trimethoprim sulfonamide. Sometime you will go for even third generation cephalosporin, cefovectin or cefadroxil, all this. So these are for as a first choice of your antibiotic in superficial bacterial pyoderma. Then second tier, next step, if empirical and topical therapy are not appropriate, when culture indicates susceptible to particular. So in spite of your this therapy along with your topical, still the lesions are present, then you need to go for culture and antibiotic and specifically select the antibiotic accordingly. Mostly these second tier antibiotics are included as doxycycline or minocycline, fluoroquinolone and aminoglycosides. Then third tier antibiotic, when first and second tier are not appropriate and the culture indicate susceptibility. For example, mainly methicillin resistant staphylococcal pyoderma or multi-drug pyoderma are coming under this group, and they are susceptible to linezolid, teicoplanin or vancomycin. So these drugs are not routinely used unless you prove there are resistant strains are there, and you go for culture and sensitivity and other diagnostic thing, then you go for this antibiotic. So this is the different tier system of selection of antibiotic based on the guideline given by the Working Group of International Society. So apart from that, there are various therapy have come up in the market, and that is a bacterium, that is a kill the bacteria, are used for say immunomodulatory autogenous vaccine. That is from the bacterial lesions, they will isolate the bacteria and they will develop a vaccine accordingly. And there are non-bacterial immunostimulants are there like levamisole and cimetidine, but they are not routinely used in practice. So this is the important part of this lecture, that is recurrence of pyoderma, or you can say resistant pyoderma, or often factors that is complicating the therapy or making the therapy as a failure. So one thing is that first we can say inappropriate initial therapy. So the antibiotic selected may be wrong, or the course of treatment given may be inappropriate. The owner complaints may be poor. They could not have given the antibiotic to the full course, so there will be reoccurrence of infection. So dosage or duration or antibiotic selection. And deep pyoderma, bacterial infection are a common cause of recurrence of deep pyoderma, or mainly gram-negative organisms are common. And suppose in spite of your selection of antibiotics appropriate, and you are given for a stipulated period of time, even then you are getting remission of signs, that is a reoccurrence of a clinical sign, then you need to go for complete diagnostic workup. Your dermatological history is important, distribution of lesion, and certain diagnostic tests to rule out atopy and food allergy, flea allergy, and presence of external parasite, or seborrheic disorder, or follicular dysplasia, or sebaceous adenitis, or other infectious diseases like Madras or dermatophytosis, and diseases that lead to weaker immune system like iatrogenic or endogenous hypercorticism, hypothyroidism, or there is acquired immune deficiency. So they may be present. That may be the reason for the occurrence of disease frequently. So if such occurrence, reoccurrence is there, first you go for, if you suspect flea allergic dermatitis, go for flea control, go for some spot-on therapy, and do deep scraping, rule out demodicosis, and give specific treatment for demodex and antibiotic. And if you suppose sometime you may not appreciate mite on the scraping in chronic cases, in that case you can go for a treatment trial for scabies like ivermectin therapy, and then topical lime sulfur like that. And if you suspect underlying hypoallergic, that is cutaneous adverse food reaction is there, you can go for elimination trial, go for novel protein or a hypoallergic diet, and to rule out cutaneous adverse food reaction. If you suspect atopy, you can go for intradermal allergy testing and desensitization with allergen. And if you suspect endocrinopathy, go for thyroid profile and dexamethasone suppression test. And if you suspect other skin disease, then catalyzation disorder, biopsy. So these battery of tests are needed in to rule out recurrence of infection. And this is the thing important: multi-drug resistance or methicillin resistant staphylococcal pyoderma. So one interesting thing is this methicillin resistant gene is present, or the staphylococcal bacteria will undergo mutation due to the antibiotics are administered at lower dosages and lower frequency and short period of time, and often it will lead to resistant strain development in the bacteria. So very common thing, we also did research on this area. We have found that is methicillin resistant staphylococcal pseudo intermediates. If you identify methicillin resistant staphylococcal aureus organism are there on pet with a bacterial disease, always you suspect it is from the dog's environment, or it may be from the human side. It is contamination of the human Staphylococcus aureus or the dog skin. And sometimes, so for that, we need to go for, that's why whenever there is recurrence of infection is there, go for cytology if bacteria are present, culture and antibiotic sensitivity. So in a methicillin-resistant pattern, you can see the absence of colonies around the methicillin disc. And so there's sometimes not only in methicillin disc, multi-drug resistance also documented in our study. Like it may be resistant to multiple cephaloxacin and methicillin and then fluoroquinolone and doxycycline. Multi-drug resistance also there. In those cases, based on the sensitivity, for example, in this case, linezolid, amikacins are sensitive, enrofloxacin is resistant. And this isolate linezolid, amikacin, enrofloxacin are sensitive. So, multi-drug resistance or methicillin resistance are now the important part of research that is emerging challenges to the veterinary field in dealing with PYODERMA. So these are some of the case reports I'm just showing. That is, this is a German Shepherd dog presented with acute moist dermatitis. So you need to think about underlying flea allergic dermatitis. This same flea allergic dermatitis, just imagine how the lesions are highly traumatic lesion, exudative, erythematous, and this is on the dorsal aspect of the body. So the distribution of lesion will give you a clue about the nature of the disease. So it's an ND dog presented with flea allergic dermatitis. So you have lesions around the eyes, that is periocular and ventral aspect, erythema, involvement of genitalia. Always think about atopic skin disease along with erythema on the concave surface of pinna. So this is a lab that is littered month back. It's an intertrigo. So oozing dermatitis, you can go for lotions, cream along with some antibiotic therapy also. So this is a contact allergy dermatitis. So the lesion is epidermal colorate, but always you need to analyze the underlying etiology based on your detailed history taking and distribution of lesion. This is the contact allergy. It's also very common. And in this case, acute moist dermatitis on the neck region. This is unknown etiology, but the lesion noticed 2 days after injection could be a drug allergy in this dog. And this is also a contact allergy. You can see the highly erythematous with the small pustules on the ventral abdomen. And these are all very common presentation. That is a deep PYODERMA. You can see the oozing red mange lesions. It could be a focal or generalized. In short-haired breed, mostly it is presented at alopecia with, especially in pug dog, you can see only hyperpigmentation with alopecia. So it's a PYODERMA secondary to demodicosis. And this is the important part. So whenever the dogs are presented with it, so from distance you can see only intact hair coat and the skin, but you can see the here and there is raised nodules. These are all called as papular eruptions. If you reflect the hair, you can see the nodules, small papules under the hair coat, and these dogs are often presented with intense pruritus, otitis, and then recurrent PYODERMA. Papular lesion. Always you go for elimination trial to rule out cutaneous adverse food reaction. And another thing in hypothyroidism also, you may come across a papular, that is a recurrent PYODERMA in hypothyroidism also. So like these lesions in the interjudicial space, pars and interjudicial. So it is a cutaneous adverse food reaction or atopic dermatitis. Both the case you will get lesions on the pars, that is erythema in the interstitial space. So sometimes in a hairy breed, you may not appreciate the lesions. The owner present only scales and crust on the hair coat with intense pruritus. So this dog total clipping, you can appreciate the reddish papular eruption throughout the body. So this also favors for topical therapy is the penetration of the medicaments. And this is the pyoderma. You can see the pustular tract on the skin with a matted hair. So this is the actually chemical contact based on the history. You can say it's some kerosene allergy. You can see the ulcerative with the scabs on the thing. So this is the actually looking like a pustular lesion, scab throughout the body. This is actually this owner has used thick shampoo. It's actually allergy skin reactions. So this is lab 3 weeks, as I said earlier. That is around muscle. You are getting ulcerative lesions on the periocular also. This is a juvenile cellulitis. This is another interesting thing. You can see the pyoderma secondary to iatrogenic, that is hyperadrenocortism. It's called as Cushing. That is calcinosis cutis and the hyperpigmentation, thinning of the skin, comb downs. So this may occur either due to the systemic steroid administration, chronic usage of corticosteroid. Sometimes the people may use for like a local topical gel or cream containing steroid containing cream. Long-term usage also may go for localized skin atrophy and comb down and the other lesions. It is a iatrogenic hyperadrenocortism. So immediately you need to withhold the steroid therapy orally or application of steroid containing topical ones. So this is the chin pyoderma. You can see the skin fold pyoderma near pug, and it's all kind of a surface pyoderma. So what are the thing? By seeing the lesion, always immediately you cannot come to conclusion what is the cause for pyoderma. So you need to go for stepwise. Minimum scraping is necessary to rule out the parasitic, and then go for stepwise thing. So as a to conclude with, to avoid the recurrence of disease to get complete clinical remission, we need to control the underlying primary disease. That is the top priority. And cytology and cultures are essential to avoid resistant bacterial disease. And proper selection of antibacterial drug is important in recurrent pyoderma based on ABSD. You need not go for even culture. Mere ABSD will give you clue in the selection of antibiotic. And another important, antimicrobial drugs are administered. That is, systemic therapy is continued even after complete remission of clinical signs. And topical therapy is alone is useful for superficial pyoderma. And any of the pyoderma, you should not include a steroid in your protocol, except in a surface pyoderma if it is so traumatic and pruritic, short course you can administer steroid, but otherwise steroids are not at all included in our protocol. And above all, your veterinarian role is 50% and client's role is 50%. Unless the clients are cooperative, you just educate them. If the complaints is good, you will get a very good improvement in the disease. Thank you. Yes, sir.
Thank you, Dr. Kavita, for taking us on a journey of canine pyoderma. We have a few questions.
Sir, thank you, sir.
Whenever we are talking about dermatology, after a full session, people have the similar questions. So the first question here is, which antibiotic is the best for canine pyoderma?
That is the topic. No, I have elaborately explained. Okay, no problem. So, shall I answer, sir?
Yeah, ma'am.
Yeah. So once again, it depends on the whether it's only a surface pyoderma, you go for topical therapy, or systemic therapy you want to select. First choice is your either amoxicillin with clavulanic acid or cephalosporin groups. And in a recurrence case, you go for fluoroquinolone. Antibiotics in challenge D PYODERMA, based on the ABST, you can select the antibiotic. So the important is you need to identify the underlying pathology. So with a mere selection of antibiotic, you will not get success because all the bacterial disease are secondary. So yeah, there is nothing. If you are going for higher antibiotic, you will get remission. No. If the problem is adverse food reaction or atopy or due to Demodex, so whichever the antibiotic is you are selecting, it will not be of useful. So diagnosis is important. That is underlying pathology we should diagnose.
So just emphasizing what Madam wants to say is generations of antibiotic is not important. Diagnosis is important. And she said in the initial part that you need to have a longer therapy so that there are no relapses, there are no resistance of the case.
Yes.
Ma'am, there's a question from Dr. Jacob Matthew. He's from Secunderabad. He's a private practitioner. He says, we usually observe lesions around the testis. So what type of pyoderma could it be and what would be your suggestions for the same?
Usually, whenever the genitalia alone very rarely affected, it could include other region also. Normally, any allergic dermatosis, atopic dermatitis, food allergy dermatitis, you may get any immune-mediated skin disease, your testicles are get compromised. So, very rarely you will get scrotal eczema also as a unique. Otherwise, most of the time it is manifestation of allergic skin disease only.
Right, ma'am. Another question which emerges out of most of the presentations and most of the sessions is we always recommend that we should go for pyoderma, for even mastitis in large animals. We should go with parenteral and topical or intramammary therapy together. So which is the best? Because usually people write out here that we don't have the same oral and the same parenteral, or the same oral and the same topical. So what could be the good combinations for the same?
This will not, because mastitis is different entity, same antibiotic, injectable or intramammary. But in pyoderma, topicals, if it is shampoo, because generalized pyoderma, superficial folliculitis is there, you are going for shampoos only. So the shampoos usually contain benzyl peroxide or chlorhexidine. That is the thing. If it is a topical that is a gel or cream, they are having either motocin or sulfadiazine or neomycin like that. So whereas systemic antibiotics are entirely different, they are fluoroquinolones or sulflexin. So once again, in generalized skin disease, along with the topical shampoos, if you administer systemic antibiotic, the remission will be earlier. So it will give earlier remission if you go for only systemic therapy alone. So combination is always will work. Sometimes, like in surface pyoderma, only topical antibiotics are sufficient. Likewise, the underlying pathologies like atopy or food allergy or endocrine disease are there. Only topical shampoos you can maintain, even you not go for systemic antibiotic. You need to address the primary etiology.
The next question is, any best treatment that you would suggest for melasthesia?
Melasthesia, going away from the thing. No problem. Once again, melasthesia also, it is a primary or secondary. So all the infectious agent, you can say it is a primary or secondary. So melasthesia can occur primary or secondary to atopy or endocrine dermatosis. So even you can manage with topical if the underlying pathology is atopy or endocrine dermatosis. With a mere topical, you can maintain either like micronazole or ketoconazole shampoo. And another thing, any microbes, if you reduce the skin pH, the multiplication is that you are curtailing the multiplication. So the vinegar, that is a normal kitchen vinegar, 1:1 with water, you can apply on the skin and leave as such. So twice a week, if you do like that, along with antifungal shampoos, you can maintain the, you can reduce the colonization of Malassezia. If the infection is so severe, you need to go for along with the topical systemic antifungal drugs.
You highlighted a good point of vinegar, so thank you, madam. The last and the final question is, there are a few sprays which are existing for pyoderma. So do you suggest the same? Most of them are with steroids. So
yeah. For a topical, that is surface pyoderma, you may use this topical sprays that may contain steroid along with the antibiotic. It may work for some time. You should not use any steroid containing preparation for long term. Suppose you are saying surface pyoderma like a hot spot on your back, you are temporarily giving steroid and antibiotic, but unless you take care of fleas, you go for spot on, then you will not get reoccurrence. So often you need not go for topical preparation alone. You address the underlying thing, go for spot on periodically, so that animal will not go for allergen-based dermatitis.
with that, we come to an end of the question answer series, ma'am. We thank you on behalf of AVD INTAS for this webinar. I think Dr. Nagaraj is yet another expert in this segment. So
Yes.
I'll request him to conclude the sessions.
Yeah, it's very interesting to hear your lecture. It's very nice, and most of the things are covered in that. So as you said, we have to concentrate on the primary rather than the only attacking the secondary. So the secondary has to be see into it. Apart from that, primary cause also has to be covered. Well done, Dr. Kavita. Thank you for your cooperation in presenting this webinar. Thank you, everyone. Thank you very much.
So at the outset, I thank our organizer, Dr. B. Nagarajan sir, professor, and Dr. Nitin Bhatia, Intas Pharmaceutical, and all other practicing vet and students for patient listening. Thank you for this opportunity. Thank you, sir. Good night. Thank you.